the panel discussion now. So welcome back to Rob Stewart, to Mark Brown and to Sonia Johnson, who are going to talk, and welcome to Raza Griffiths and Helen Gilbert, who are going to join the panel. So just so that you get to sort of meet Raza and Helen and know where they're coming from before we start sort of questions from the panel, I'm going to just invite them each one after the other to briefly sort of give an initial comment on what we've heard and what they've been doing. So Raza, hi.
Hello
really
there.
Yeah.
Hi, thank you, Bryn. I must admit I'm feeling incredibly exhausted, and I think that's one of the kind of disadvantages. It's lovely to be able to see all you people, but I'm feeling very, very exhausted, and I've been eating some frozen banana because of my low potassium levels. That's why I've been eating. But anyway, I'm a mental health service user and campaigner for many years. I know many of the people here. It's lovely to see you. So I was particularly involved in the staff survey of the impacts of the pandemic on mental health care staff, and also the international synthesis on the impacts of COVID. So those are the two main projects that I've been involved in at the Mental Health Policy Research Unit. So I've been reflecting on some of this, plus my own experiences. And in terms of priorities and themes for future mental health research, these are some of the things that I think are priorities. So the first one is the intersection of physical health care with mental health care. One has to remember that mental health service users have very high morbidity, more physical illnesses than in the general population. So of course, during this pandemic time, there's been a loss of access, in some cases, complete loss of access to many aspects of physical health care. So you have to take both those things into consideration when looking at the overall well-being. I mean, of course, physical ill health often has an impact on mental ill health as well. So that's a really important intersection that we need to explore more carefully. The second intersection is of mental health diagnosis and ethnicity. I mean, I think it's particularly striking that at a time of profound social focus on issues of racial inequality, systemic racism, and all the rest of it, the staff survey, which interviewed more than 2,000, mental health staff, and you have to remember that BAME communities are overrepresented in the workforce, hugely overrepresented, and also hugely overrepresented in the mortality statistics. BAME nurses are particularly prone to dying. So given these three factors, why were less than 10% of the sample from BAME communities? And I don't ask that in an accusatory fashion, but I think we need to pause and reflect on that. Is it a lack of engagement generally? Is it a lack of trust? I mean, if that is the case, and I don't think we've established why, there may be other reasons, I think that very much reflects the kind of disengagement of BAME communities, BAME activists and service users from trying to kind of engage with the system and improve it and getting our voice heard and making a difference. So those are the two intersections. I think a third issue of concern to all communities is the therapeutic environment or lack of it. Because what we know is that we're starting from baseline, particularly on inpatient wards, where there's often a lack of a therapeutic relationship. The culture on wards is one of them and us. And of course, the very massive issues of the use of detention and control and force have always been there. And my question is, has this increased as a result of the kind of hothouse conditions that we're all living in and having to kind of keep separate from others? And, does this lead to increased anger and frustration on inpatient wards, which may result in more use of force and control? It's a question, and I think we need to investigate it, particularly because more recently, there was the Mental Health Act review, which arguably didn't do very much around those key issues. Also wider developments such as the United Nations Convention on the Rights of Persons with Disabilities, which is widely kind of interpreted, including by the United Nations, as you know, that we need to move away from force and control and the rest of it, but has the pandemic kind of taken us in the other direction? So the other issue which we need to really look at is the kind of differential impacts of COVID, you know, on the population, and what are the factors that disadvantage people disproportionately? You know, are existing inequalities being reinforced, you know, in terms of poverty, in terms of, you know, if you're a single parent, for example, how accessible is online therapy if you're a single parent, if you don't have a sense of privacy in your own home, if you're in an abusive relationship, is it a safe environment? So, you know, we need to look very carefully at how different groups are differentially affected and try and ensure, I mean, I'm guessing we're all in favour of equal access and kind of equality and all the rest of it, to ensure that the services and support that are emerging out of this crisis are kind of equally accessible and equally beneficial to everyone.
Raza, that's fantastic. I'm sorry to cut you off in mid-flow. I'm slightly
just one very quick thing, which is that the speed, the rapidity of change that's been forced on the system and the way the system has risen to that. I think this signals the capacity of the system to change quicker than we sometimes give it credit for, you know, because there's so many things that we've been pressing for, wanting to change, and constantly told, oh, you know, we need to move at a snail's pace, or we haven't got the resources, etc. But I think this is a counter argument potentially to that argument.
Fantastic, thank you. There's a real agenda there, isn't there, which people may want to pick up. Just before we get to some sort of questions from the audience, Helen, Gilbert, hello. We're really glad to welcome you to this event from the King's Fund. And I don't know if you'd like to give us a sort of brief opening gambit for things that are really important, perhaps from a sort of policy perspective in particular.
Yeah, so hi everybody, I'm Helen Gilbert from the King's Fund, and I guess there's a few things I've said in the breakout as well and been picked up. I mean, the first thing really is this is a huge, massive experiment, you know, over very short period of time, things have changed absolutely massively. And I would, you know, advocate that we've effectively got a brand new baseline of where we can work from. And I think there's an opportunity to look across not just areas such as telehealth, which is brand new and is, you know, it's infiltrated so pretty much the whole of the service now, but also the changes that have happened on wards in different merging and changing of services. And there's a real opportunity to think about what does that actually now tell us about how care was, you know, if we've had to close wards because they weren't, you can't control infections, or we've had to change staffing and availability. And what does that also tell us about how care needs to be in the future? I think there's a real push at the moment for what can be done, and I would advocate very strongly for also having a very strong focus on quality of what the quality of care is as a consequence of some of the changes and where that needs to be. Quality has been an ongoing problem for quite a few years in mental health services, and I think it needs to be a forefront, not just of access, but also that we provide good and effective quality care. I'd advocate that mental health provision is not just provided in mental health services. Primary care services, increasingly we're doing work with them, and there's a big programme of work to try to join up primary care mental health with secondary care. And one of the big findings of that is actually, although primary care mental health is the point of access often for people with mild to moderate symptoms, actually they hold increasingly large numbers of people who have experience secondary mental health services and continue to receive care. So, you know, I'd advocate again that we look at that area. Two more points. The first is there's limited resource, although there's new resource coming in at the moment, but we need to think more about, not just about more service or more things that we can add into the system, but how we use what we've already got that's better for people. So how we make that that works better for the people we're trying to support. And the final one I say is about workforce wellbeing. So mental health services, the National Staff Survey for a long period of time, mental health services comes second from the bottom. So at the bottom we've got staff wellbeing is poorest in ambulance services, and then it's mental health services. And it feels like some things have shifted during this period just really to keep staff going. So there feels like there's a piece of work to understand actually what does staff wellbeing look like in mental health services that's going to be really fundamental for recruitment and retention, because staffing is a key issue. So those are my sort of top advocate for.
Lovely, thank you, Helen. That's another great series to take forward. Okay, so we now have a little brief time, and I believe Alan has been sort of trying to look at the chat and has got some questions that pick out some of the themes that have been coming out through the day, which can be addressed to all 5 of our panelists really to chip in as they see fit.
So there's been all sorts of questions, and I've tried to group some together, composite questions. So I'm going to kick off with one which has been a feature in a number of the chat entries. People like Tamar James, Tina Colden, Peggy Malongo, Alison Faulkner have all been asked around issues around Black, Asian, minority, ethnic communities and the impact of COVID and the impact on them mental health services. So a sort of a combination question really is there, or why is there limited evidence about the perspectives of people from those communities in a lot of the work that's been undertaken? Are there, or should there be more appropriate treatment interventions for Black, Asian, minority, ethnic patients in the community? And given that Black, Asian, minority people seem to be more affected by the impact of COVID, and certainly if they have mental health problems as well, should they be a priority for vaccination and improve access for physical care in mental health services? So a nice little combination, but the issues around Black, Asian, minority, and ethnic communities. Nice, easy one to start with.
Mark, I see you coming in.
Mark, thank you.
Well, like to me, on some level, it's really obvious. The problem is everyone's freaking white, more or less.
Yeah.
And the pipeline between wanting to do some research and getting people to pay attention to you as a researcher is very long and requires a lot of resources and investment that you may not have access to. You know, so it's a very obvious point to make, but just in the way that charity is so white, research is so white, and if we're talking about all these issues around race and ethnicity and stuff like that, there needs to be some people giving up their space in wanging on and making space for other people to have the opportunity to wang on. and you know, that's the simple thing. Yeah, I just, you know, I can't tell you what a Black and minority ethnic community, a community in any of the places across the UK needs or wants or really wants to find out, or what's really affecting them. We need to find mechanisms by which we can just let people get on with it and do a good job of it.
Thank you, Mark. Anyone else on the panel? Sonia, please.
Yeah, I'd say, I mean, Andre's just posted a link to a recent mental health question time that I think covers this whole issue of inclusion in research extremely well, and I'd recommend looking at that. Just to say, although we were very disappointed by our staff survey, despite various attempts at networking with relevant organisations, and we still ended up with only 80-something%, only a bit under 90% non-white staff. We did do somewhat better than that in the interview study, the service user interview study that people have talked about, where I think only 50-something% were white British, and there was rather better minority representation. And that was really because particularly Josephine Ocklew, who works with you, Alan, and a couple of other people in the group made just huge efforts to pursue all sorts of voluntary sector avenues to really find all sorts of innovative strategies for getting a somewhat more diverse sample, thus showing that if you're the right person with the right connections, you can get somewhere with that. And I think
increasingly now with the whole Black Lives Matter movement and everything, that I think universities are really starting to look at themselves and think about, what do we do? I know at King's we've been doing a lot of the work the last few months of trying to think about how do we bring in and promote and support more Black, Asian, minority members of staff, and it is a big issue, isn't it? It's about having credibility with those organisations when we go to them. Otherwise, it feels very exploitative. Anyone else want to chip in on that question before we move on? Raza, yep.
I just want to say that I wasn't involved directly in the interviews and sampling all that for the survey. I mean, were there no BAME NHS staff networks that could have been, were they approached?
Yes, they were approached, lots.
Yeah, and we use targeted publicity and so on and so forth. But there is quite a literature around why, some of the arguments of why perhaps people don't come forward and don't respond. And a lot of it is about previously feeling their voices have not been heard and not been responded to. And I think that's a good point. If you don't feel anyone's going to change anything, you stop bothering. And I think we've got to engage with that issue. It's a real issue. Should we move on to the next question? Thank you. Alison Faulkner, I think this is a good question for everyone involved in these research that's been going on, different types of research. Are there any concerns about the validity and the ethics and the quality of this research that's all been conducted at some speed? Obviously not.
Oh, shall I go?
Go on, Sonia. Go on.
I think there's necessarily a balance between what you can do very quickly and what you would like to do if you had longer to set things up. For instance, looking at a sort of wider range of channels for recruitment and recruiting through the NHS, which was not really feasible in the time available. I mean, I guess I'd say that I hoped that using a sort of co-production approach meant that we got a lot of good advice and good inputs into trying to work quickly on it, and that an awful lot of different people with different perspectives, both staff and service users, had inputs to the study, and that was very helpful. We also did have, I think, full ethical approvals, at least from university committees, which were able to scrutinise what we were doing at speed in a way that isn't normally possible, and at the moment is only possible if you do COVID research. Actually, everything else is slowed down, but that gets considered quickly.
I think as well on the ethics, I think there are certainly in our team, there were an awful lot of discussions around the ethics of what we were doing and the sensitivity of some of the work, and a lot of thought put into how it was done. And I don't think these things are done without that consideration, but no doubt some things could be improved. Does anyone else want to come in on that issue, Speed? Rob?
I can say, yeah, I mean, in terms of ethics, what I was presenting was covered with existing pre-COVID frameworks. It was anonymized information, so we didn't have to apply for anything new. We tried to assemble a specific service user advisory group as quickly as we could. I think we probably could have done it quicker, but we managed to get one in order to kind of sort of make sure there was co-production and sort of a decent amount of input into what was being done of a COVID-related nature. In terms of the quality, I think there's a tricky balance with the peer review system. The peer review system just doesn't work for getting information out there quickly. As I say, we managed to turn around a paper in April, publishing on sort of data that was emerging up to March. We got 1 or 2 peer reviews that were nothing to do with the quality, just to do with we don't think this is interesting. And by the time we'd gone through that process, the data was out of date. So what was the point of that? So I'm a great believer in the ideal peer review system, but I just don't think it works for a situation like this, in which case, yes, you have to put things out there and hope that they're as good as possible in the absence of peer review. What we did was try to put information out there that was blindingly obvious what we did, as in it didn't involve anything sort of complicated. It's just straight descriptive data. Look, here's the South London and Maudsley, this is what we found. We're not saying anything more than that. Take it, you know, that's just what we found. We didn't make anything extra from it. So, but I don't think the world has sorted itself out on this.
No. Mark. Thank you, Mark. Mark.
Yeah, I was just going to say that in some respects, the question here is what is the jeopardy involved in getting it wrong or doing it badly? Like, thinking about research, there's all the stuff about ethics, all the stuff about, you know, safeguarding and making sure peer review and stuff like that. But really, it comes down to what will happen in the world, or what potentially will happen in the world, if you cock it up. And I think that's the thing. The moving at pace stuff really makes me think about, because unlike research in normal situations, the research is actually being acted on and shifting public debates in real time as it's published. No one's having a chance to sit on it, no one's having a chance to scrutinise it, no one's having a chance to synthesise it, or at least not in the same places that the discussion's happening. And I think that's why you have to be really, really careful. Like, who might use this badly and what might they do because of it?
There's also, of course, a price to be paid for no research and no evidence. And certainly with the PRU, our feeling was that in the sort of, at least in the kind of research that's in the scientific literature, mental health services and people with pre-existing conditions weren't really becoming part of the discussion or being looked at. So there's an important price for if there isn't any evidence around.
Absolutely. Absolutely. Helen, did you want to add anything to this?
No, I think Sonia's just picked up that. I mean, coming from a policy perspective, everything was changing on a daily, weekly basis. So actually, some of the papers that you put out, you know, for all the flaws they've got, gave us a position of actually what's happening at scale across the country. And I think even research that's not, you know, setting a ground mark of, you know, this is the you know, the gold standard quality of what we know of you know, what we should do and implement, actually, while a lot of the research at the moment is sort of just capturing what's happening. I think it's almost like we're not starting from a standing point, it's already happening, and if you don't research it, it's going to happen anyway. So it's better to try and influence the direction and also, you know, know where to roll back on some of the things that have already happened.
Yeah, I agree. I think it's a little bit like the swift changes in service delivery. There's been swift changes in research delivery as well, and many positives with that. But also we need to be alert to the safeguards that are there for good reasons, because of historic abuses, and we need to be mindful of that and to be cautious. But probably it has changed the way we think about how we do research, and that's probably been a good thing. I'm going to move it on to another question. There were quite a number of questions from different people, not least Ben, I've lost his surname, Glass, who were asking about what seemed to be a disproportionate impact of COVID on people with learning disabilities, with autism, and particularly people in perhaps longer care, institutional care. And any thoughts about that? Because I'm not quite sure how much our research focused on that, but or other people's, but any particular thoughts around that, the challenges of doing research in those areas?
I guess as much to say that this is almost like COVID more than anything has highlighted the huge inequalities in society, and this is a group of people, particularly those who are institutionalized, where actually national policy and services themselves have done really badly by. And I think again, this is, you know, it's not unique to COVID, but it was really, COVID's really highlighted that this is a group of people. Very much what's happened to people with learning disabilities and autism, and those people particularly in institutions, is really reflective of what's happened in the wider care sector, as opposed to what happens in mental health services. And there's been a strong sort of sense of this group within the mental health world has been out of sight and out of mind quite a lot. And so I think the more that we can do to see them as part of, you know, as a bigger picture, and highlight the particular inequalities that this groups of people have experienced as part of that, the more, you know, the more we'll be able to move things forward.
Yeah, I'm aware that colleagues of mine in Florence Nightingale Faculty of Nursing are doing research in care homes around the impact on staff and on residents, but particularly people with dementia rather than learning disabilities. And I do think that's often a group population in our communities which are underserved, as you say, Helen, probably reflecting some wider prejudices that are going on.
Just to highlight that there is a paper that our colleagues wrote with data from our staff survey, isn't it, reporting the perspectives of people who work with people with intellectual disabilities. So I think it's worth looking at that just for a start.
Absolutely.